Good morning. We will get started in just a moment. Again, good morning and welcome to our webinar, Ethical Practice in a Virtual World, Ethics and Use of Technology in Healthcare Service Delivery, with our presenter, Dr. Jill Stinson. This webinar is co-sponsored by the Great Lakes MHTTC and SAMHSA. The Great Lakes ATTC, MHTTC, and PTTC are funded by SAMHSA under the following cooperative agreements. The opinions expressed in this webinar are the views of the speaker and do not reflect the official position of the Department of Health and Human Services and SAMHSA. The MHTTC network believes that words matter and uses affirming, respectful, and recovery-oriented language in all activities. For more upcoming events and information, please follow the Great Lakes MHTTC on social media or visit our website. A few housekeeping items. If you're having any technical issues, please message me, Jen Winslow, or Alyssa Kuala in the chat section at the bottom of your screen, and we will be happy to assist you. If you have any questions for the speaker, please put those in the Q&A section on your Zoom toolbar rather than the chat. We are going to reserve some time at the end of this presentation to answer as many questions as we can. If you need live caption or a transcript, please enable them by going into the More section of your Zoom toolbar and select Live Caption. At the end of this session, you will be automatically redirected to a very brief survey. Certificates of attendance will be emailed to all who attend this training in full. Please allow up to 2 weeks to process. And now I want to welcome our presenter. Dr. Jill Stinson is a licensed clinical psychologist and associate professor in the Department of Psychology at East Tennessee State University. She received her dual doctorate in clinical psychology and psychology, policy, and law from the University of Arizona prior to serving as the director of sex offender treatment at Fulton State Hospital with the Missouri Department of Mental Health. Her teaching focuses on professional ethics, forensic psychology, and psychological assessment, while her research focuses on serious mental illness, personality disorders, self-regulatory problems, and histories of early childhood maltreatment in persons who have committed violent and sexual offenses, as well as issues related to community re-entry, stigma, and suicidality in justice-involved populations. Dr. Stinson has authored 3 books related to etiology and treatment of sexual offending and motivation to engage in therapy. She is the incoming editor-in-chief for sexual abuse, chair of the ETSU campus IRB, and secretary of the board of the Council of University Directors of Clinical Psychology. So welcome everybody again, and I will turn it over to you, Dr. Stinson.
All right, thank you very much for that kind introduction. I'm glad to be with you here today. We are going to be kind of running through quite a lot of material. So if you'll save your questions till the end, I'll reserve plenty of time, and some of your questions may be answered as we go along. Just advance my slides here. All right, so our learning objectives, we're going to be talking about ethical concerns specific to virtual service delivery, responses to the challenges that we may encounter, and then how to mitigate limitations in use of technology in our work. And so starting out, this is the most recent or current definition of telehealth or virtual technology use in healthcare available from HRSA, or the Health Resources and Services Administration. And you can see here that it covers a lot of ground. So it includes electronic information, telecommunication technology for healthcare, education, administration of healthcare services, and general public health measures. So that incorporates quite a bit. This particular definition has, as you can imagine, evolved substantially over the past 5 years. Prior to COVID, it was a much narrower definition, as many providers weren't using a lot of telehealth prior to 2020. They weren't using webinars like we are today as commonly or as frequently. And as the technology has advanced, this definition has also definitely evolved because we now have technologies that we did not several years ago. So when we look at this, we're talking about a whole range of different technology uses to promote healthcare and healthcare education. Video conferencing is probably the one that people think of most when we think of use of virtual technology in healthcare, some form of this, Zoom or other platforms that we use. Many of you may remember Skype. I think Skype has kind of gone away, but that's usually the go-to. But this also includes phone calls, emails, and texts involving patients, to or from patients, involving patient care. Entering data into web-based assessment platforms. So many of our assessment instruments in psychology now have web-based platforms available where you can just send your patient a link and they fill out the assessment and you get the results right away. This could also mean recordings, photos, documents, remote patient monitoring if you're monitoring your patient's mood or behavior via their smartphone or some kind of app on their phone. Again, synchronous, asynchronous technologies that we may use. If you listen to this webinar later recorded, that's, asynchronous learning. And then we think about the use of streaming media and how that has also been incorporated in a lot of our treatments when you have patients engaging with some kind of streaming media platform, whether it be for a psychotherapy homework assignment or an educational video that you want them to watch. So a lot of different forms of virtual technologies that we now use in our practice. As I mentioned, prior to COVID-19, many people were not using technology to the degree we are today. I mean, obviously things like emails and phone calls and text messages were still in use in healthcare, but we've seen a great expansion of that. And there are a lot of advantages to using these technologies in your practice. A primary one is accessibility and reach. We've just seen vast improvements in our ability to make treatment more accessible to people, to limit transportation barriers, things of that nature, to reach populations or people that we might not have otherwise. I don't know about all of you in attendance, but I know that the clinic that I work in here at the university, we saw a dramatic increase in clients keeping their appointments when they didn't have to worry about transportation barriers, childcare during their session, things like that, where they could just remote in from home. We saw many, many more people attending on time and attending for the whole duration of their appointment. We also see that virtual technologies can increase the availability of specialty providers, people who otherwise might not be available to folks in their region, or a specialty that's more rare or nuanced. They might not get to ever talk to that person. I know in the region that I'm in, we're very rural, and in many cases, people are driving hours upon hours to seek specialty care, and that mitigates this particular burden when you can access those providers remotely. It also is more convenient for folks. We noticed that people were also telling us that it was much easier to schedule appointments when they didn't have to schedule in transportation time or traffic, things like that. It was much more convenient for people to just have a quick session from their home. And that may be true for providers as well, because there's a whole range of methods that we use for, doing therapy, doing assessment, what have you. I know, for example, I when I do assessments and I can send them that link and they fill it out, I don't have to sit there and wait for someone to complete an MMPI in the office, for example. So it's also more convenient for me. There are some cost savings associated with using these technologies to promote our work. We see that people are better able to staff, for example, if they don't have a lot of folks coming in to the waiting rooms and waiting. We found that we were able to transfer smaller rooms and make them telehealth rooms in our clinic, whereas we might not be able to fit a whole family in a very small space. We could do the therapy session virtually with a much smaller space available, so we were able to do more with that. I'm sure that that translates to a lot of other facilities as well. And then finally, the major reason that most of us had to suddenly become very familiar with different virtual platforms was health and safety. But it also has continued in that we can make sure that if someone is ill and they're well enough to attend an appointment, but we don't want them in person because they may still be contagious, we can still have that appointment with them. If you work with children, for example, you know that children are sick a lot, right? I have two. I can speak with certainty that their school is rife with germs. So, if someone has an ill family member and you don't want them to bring things into your clinic because they have a child who's ill and may be contagious, you can still see them, right? So those benefits have persisted. However, there are some concerns, and these are things that some are easier to mitigate than others. Some concerns, we've seen a lot of development of alternatives that help with these, but anytime you're going to be using virtual modalities in clinical practice, you're going to see people talk about, how easy is the technology to use, not just for providers, but also for clients. Are clients going to be familiar enough with the technology that they are able to use it effectively as a tool and not something that then hinders or serves as a barrier to effective treatment? We always have technological problems that can interfere. If you are concerned about your connectivity or whether or not this text message that you need to send for a patient reminder is going to go through, there are always going to be those hiccups in the use of technology that can make things more difficult. A major concern a lot of people have had and expressed many times when new things come out is security and confidentiality. And how do we make sure that if we're doing therapy, for example, via a Zoom platform, how do we ensure that that is going to be a secure means of discussing sensitive patient information, that other people can't hack into it? If we're sending emails, how do we make sure that those emails can't be intercepted or seen by other people? So those remain pretty significant concerns, even with the current existing technologies we have. But again, as new ones emerge, that is a first line question as well. Is it safe? Reimbursement can be a concern as well. I think most jurisdictions have, or jurisdictions, mainly insurance companies, but most have caught up with this idea that these sessions should be reimbursed at the same rate. But initially, a significant issue that was occurring for many individuals who had to switch to virtual service delivery was insurance companies were saying it's not the same. And so we're not going to reimburse you at that rate that you're normally reimbursed when that person is physically sitting in your office. And for us as providers, as I often remind my students, we go into clinical psychology because we want to help people, but you don't have to hurt yourself to do it, right? And so, if there is a reimbursement issue, we still deserve to get paid for our work. And so I think this has been an area that a lot of lobbying efforts from state psychological organizations and APA have helped mitigate this concern, but it may still exist for some or for some specific forms of treatment. Another concern is, how do I engage my clients effectively? Is this the same? And we'll talk about this with regard to specific areas of ethical concern, but there are some differences in client engagement, just as there are in training and learning and a webinar, right? Like, I can't see any of you right now, and that's odd to me. It feels like I'm sitting in my office talking to myself. And so there is a very different feel of engagement using virtual service delivery. There's a different feel for Zoom. There's a different feel when you receive a text from a client or an email from a client and you can't read tone. So that is something that we have to consider when we're using this in our work. We think about engagement, we think about quality. Because of some of those differences, because of potential technological problems, is the quality of service going to be what I would normally think it is, again, if this person were sitting in front of me in my office? And there's a lot of variability in that. There's variability in how different people perceive the quality, and we have to be aware of that. An example I can give you from my realm of work, I'm a forensic psychologist, and the research is showing us that when people do risk assessments for the court using virtual technologies, when they do, a video conference assessment of an individual who might be at risk of violent behavior, evaluators feel pretty confident that their conclusions are sound and that their conclusions are just as valid and well-based in scientific knowledge as if they saw the person face to face. So psychological examiners feel pretty good about it. But what the research shows us is that judges and lawyers do not. And so judges and attorneys, both prosecutors and defense attorneys, do not feel that those risk assessments that are done using video conferencing are as good, are as accurate, are as certain as if the person is in the room with the individual. So here we have this disconnect between the people who are providing the assessment and the folks who are receiving it and interpreting it and making decisions based on it. And so an important aspect of this concern is it may not just be whether we think the quality is as good, but if other people, whether it be our clients or those to whom we're communicating information, think it's as sound. And then finally, a concern, and this doesn't represent all of them, certainly, is boundaries, right? It's very different receiving a text message from a client than having them call your office and leave a voicemail and you return it during business hours, right? Or having them have your direct cell phone number or email or something of that nature. There's the concern about, does this blur boundaries, and how do we kind of think through that in advance and account for that? And then how do we address that when boundary violations may have occurred as the result of the use of these technologies? So this is a huge list, and I'm not going to go through all of them because a lot of this is covered in the talk today. I have 90 minutes overall, so this is a quick run through, but these are just some of the ethical considerations and areas of our ethics code and our state ethical guidelines that are impacted by use of technology in healthcare service delivery. And so there's a huge range here. Many of these overlap. Some you may think are more serious or concerning than others. And so we're gonna run through quite a few of these today and talk about what are they, what should we be aware of, and then what can we do about them? Okay, as a little side note, before we jump in, I should just warn you. So I'm kind of an ethics geek. I guess that's a term. I don't know. I teach ethics for our clinical psychology PhD students every year, and I really love diving into really complex ethical situations. As was mentioned in my introduction, I'm also the chair of our IRB here at East Tennessee State University. So I will try to do my best to make this interesting and accessible because I know sometimes ethics trainings can be a little rough and feel a little dry. So I will do my best for you. All right, so our first area that we're going to talk about, our first ethical consideration, is competence. And this is whether or not we know what we're doing, whether or not we can use things effectively, and the degree to which our knowledge and ability impacts the care we provide, the education we provide, whether or not we're thinking about use of technology in administration, etc. So one of the first things that we want to consider is knowledge of laws related to various telehealth or virtual service platforms. And so different jurisdictions have different rules, right? I'm in Tennessee. And so in Tennessee, if I see a client using something like Zoom, they must be physically present in the state of Tennessee. It doesn't matter. Tennessee may be their residence. We're really close to the border. They may have gone over the border to North Carolina for the weekend. I can't talk to them legally, even though their residence is in Tennessee. Different states have different rules about where you are, about where the patient is, And this can apply to supervision, which we'll talk about later as well. And so one of the first things is to be really aware of what the different laws are related to your licensure board, what sorts of technologies you can or can't use. These may be organizational policies as well. You know, you may want to use a certain platform or service that your organization says, no, that's not the one we use. They've determined that one's not meeting our security standards. You have to use this one. You know, with the introduction too of SIPACT, for those who aren't familiar, it's an effort to make this more broad across the US. And so it takes away some of those jurisdictional restrictions, but you have to be a member and your state has to be a member in order for that to apply. So one thing is not just competence in providing services or using the technology, but do you even know what you're allowed to do and what you're not? And that's really important. We also have to be competent in the limitations of available technologies. Some people, as we know, are more technologically savvy than others. Some people are really uncomfortable using certain forms of technology in their work. I know, for example, when we rolled out iPad administration of things like IQ testing and cognitive assessment, I'm not an Apple product user. And so when they handed me an iPad, I'm like, I don't understand where anything is. Right. And of course, everybody, all the graduate students got a good laugh at my expense. And I'm like, I have Android. Like, I don't know how to navigate this. And so I had to learn how to use Apple products effectively enough in order to supervise my students' work. And so that it seems low level in terms of competence, but we do have to know enough of how these things work to ensure security, privacy, effectiveness, etc. We also think about our clients and their competence in using technologies. Returning to the iPad example, we'll give those to adults, maybe who don't use tablets or use them in a very limited way, and we want them to take a test on this tablet and they're like, I don't know what to do. Hand that to a teenager, you don't have to say anything. They've already figured it out, right? So we have to think about, you know, how comfortable people are and how much we need to account for that. We want to think about the impact and our knowledge of the impact on efficacy and assessment and intervention. And so as more literature is coming out about, you know, are these tools effective? We need to familiarize ourselves with that. And so we need to think about, you know, what does the literature say on use of this particular instrument via Zoom, for example? You know, and test companies are going to make sure you know what the effectiveness is and what things you can and can't do using technology, but you still have some obligation to go out and make sure that that's accurate, that they're depicting it in a manner that isn't just designed to sell more test administrations virtually. But there are certain forms of assessment that may be better, right? There are certain forms of assessment that people have a lot of questions about. If you do any kind of autism assessment, for example, there have been a lot of concerns raised about whether or not you can really accurately assess certain things using virtual technologies. And we have to know the limitations of the things that we do. And then finally, a competence issue relates to things like logistics. Things like lighting and sound and camera angles, security settings and features, and all these things that many of us may not have ever thought about before when we were just making a phone call to remind a patient of an appointment. But we have to think about that. And there's a whole series of webinars that APA had put out, that one whole like 3-hour webinar was on basically how to maximize lighting and appearance and the surroundings and how to angle things appropriately. You know, and it seemed silly, but it was things that many of us didn't know and had never really had to think about prior to everyone having to use it very quickly. So those still exist, and thinking through, you know, potential disruptions and how that might limit the confidentiality and privacy of your session. So another area to consider when we're thinking about just general knowledge are some forms of clinical practice more impacted than others? So one example is group therapy. Many people do group therapy and had to transition to doing group therapy via Zoom or other technological platforms during the pandemic. And there were a lot of concerns about how do we do this well? How do we do this effectively? And this included a whole range of concerns that go beyond the area of just competence. But again, if we think about competence being you need to know what you're doing and how it is implemented and what the limitations are. A lot of my colleagues who did group therapy by Zoom said that they were really concerned about the fact that other members of that individual's home may be able to see and hear other group members. And how do we address that? Right? They had a series of complicated contracts that they would try to implement, saying that you need to be in a private room and you can't record this session and you have to make sure no one can see or hear other people. A lot of rules about whether cameras had to be off or on, because if we think about group therapy and how it's intended to work, depending on the type of group, if it's more of a process therapy group, it can challenge the effectiveness if you can't see anybody, right? So here you are telling your story to a sea of blank faces. And is that as effective? And does it, in fact, maybe increase anxiety or cause other issues in the person who is speaking during that group time? And so, we have to think about whether or not we're prepared for some of the limitations that may happen. I know most of my colleagues who did group therapy via Zoom during the pandemic have returned to doing that in person. By and large, folks have said it wasn't a great experience. I've not seen a lot of the literature discuss this yet, though to be fair, I haven't actively been searching for it in the last year. But I know that this is something that you have to just be aware of is that some groups or people may not work as well using virtual service delivery. Others may thrive doing this. So, for example, adolescents send an average of 6 text messages per waking hour. Now, these studies were done in 2018 and 2019. I'm sure it's greater than that now. Having 2 teenagers at home, I can guarantee you it's more than 6 text messages per waking hour for my daughter and her friends. And so for them, they may prefer text-based communication with their therapist. They may prefer video clips that they can watch related to skills use or other types of therapeutic intervention. They're kind of the YouTube generation, right? So little short video clips of everything are much, much more attractive to them than watching like a whole webinar about an educational thing you want them to get in therapy. So there may be groups that really thrive using the technology. However, there may be caveats with that we have to be aware of. Adolescents in our clinic, for example, who did therapy via HIPAA Zoom were far more likely to be watching YouTube videos in the background rather than really listening to their therapist. Some of the things that we can control a little bit more when they're in the therapy room with us are more difficult to control when they're at home in their room. The number of therapy sessions that I saw my students in training administer to adolescents where the adolescents laying in their bed talking on their phone like this. Not sure if that's quite going to be the same. They much preferred it, but I don't know if it's as effective as them sitting in front of us in the office. And so we balance that, right? But in terms of competence, we have to be aware and knowledgeable about what these limitations are and where we can use the technology really effectively to engage. Okay. So then we move on to considerations of confidentiality and privacy and informed consent and use of virtual technology. So one thing is understanding HIPAA in the context of telehealth practice and being aware of what some of the guardrails are about what we do using technology and how that affects privacy and communication of patient information. One of the things that I often find challenging is, so for example, if we're talking use of video conferencing to promote service delivery, we have HIPAA Zoom, at my institution. We use HIPAA Zoom. And a lot of folks will say, "Oh yeah, it's confidential. It's HIPAA Zoom." I'm like, "Well, no, it's a HIPAA compliant Zoom platform. That doesn't automatically make it confidential." Like, you still have to do things as a provider to make it confidential. You know, it provides you a platform that is more resistant to efforts to hack in. HIPAA Zoom platforms disable recording, so you cannot record the Zoom session, although that does not prevent you from, if you're a client or a therapist, setting up a recording device and just recording the screen. But I always tell people, well, yes, it's HIPAA compliant. That doesn't mean there's nothing more you need to do. Right. And so we still have an obligation to our clients to protect their confidentiality, even if we're using encrypted devices, encrypted communications, etc. It doesn't just let us off the hook automatically. And so we still have to think about what are potential disclosures that we could encounter, breaches in confidentiality that could occur. You know, if you and your client have agreed that you can communicate via email or text, are there other people who have access to their email or their phone? Are there other people who have access to your email or your phone? And what does that ultimately mean? How do you put that client's name in your phone? And is that a violation of their confidentiality if you label it such? You know, if somebody in your household says, "Oh, this person's calling you," well, they might want to know who that is and why, right? And so how do we mitigate those risks and make it such that we still aren't identifying people in use of technology where it's everywhere and we're so comfortable with it that we might not think, like, we think, "Oh, my phone is password protected. No one else can get into it." But can they? Right? Like, do people in your household know your PIN or passcode for your phone? Probably. That's very common. And so we still have to think about that. We still have to think about, you know, if we're sending emails to patients, who sees them. Um, we had a client I know in our clinic who we were emailing information to, not realizing that that person's partner was usually the one who accessed the email account and that they had not given us a private email account known only to them, which we resolved pretty quickly. But, you know, unfortunately, nothing really had been sent out other than reminders of things, but it could have been far worse. And so communicating with your clients in advance about, you know, what does this look like? And thinking about too, privacy. I spend a lot of time, I feel like, in my life as an IRB chair, differentiating for people what is private and what is confidential. You know, privacy refers more to setting than it does information. And so client information usually falls under that confidentiality. Privacy refers more to setting. When we think about seeing a person in a traditional psychotherapy or assessment context, and we are working with them in an office, you know, we have ways of mitigating people knowing why they're there. We have, you know, white noise machines. We've got all kinds of ways that people cannot hear sensitive information or know what's going on. But when we think about people seeing their therapist from their home, we may not know what their level of privacy is. You know, I do in private practice life, beyond forensics, I do dialectical behavior therapy with adolescents. And you know, a common thing, if I am seeing them virtually or using text messaging or emails or other things, I often have to cue them, you know, make sure your mom or dad's not in the room when we're about to have this conversation. If that's something you do not want them to hear. Because if I'm doing a risk assessment for self-harm or suicidality, you know, they may not, they're sitting in their living room, right? Or they're sitting in their bedroom and they're not thinking about their sibling in the next room who can hear them, or their mom who may be in the kitchen listening. Because to them, they're at home and it's safe and whatever. And they're thinking, well, I'm just talking to my therapist. But they don't necessarily realize that the thing they're about to talk about is something that we usually talk about in a much more private almost isolated context. So we often have to repeatedly ask people about the nature of their setting and where they're at and what's going on, who all is there. You know, we also obviously have to think about our own privacy and setting as well. But I think, again, that's something we're more attuned to about ourselves than our clients. We think about screening for sensitive information in a way that maintains privacy and confidentiality. And then that security piece. So again, security features of whatever technology or instrument you're using, whether or not things can be recorded and what that may mean. And then ultimately, we want to envelop all of this into the informed consent process. And so when we're doing informed consent with virtual technologies being a part of our service delivery, we have to very carefully lay out, you know, what security measures are we taking? What are the preferences for, you know, where you are at the time therapy is occurring, and what kind of environment or setting do we want it to be in? Permissions about whether or not we can email each other or text each other. Just we have to incorporate that in, and it, as informed consent is never just a one-time shot. We have to keep having those conversations as the use of technology changes during the course of therapy. So getting more into informed consent, many jurisdictions require a specific document that is developed for telehealth or other virtual technologies, that it may not be the standard psychotherapy informed consent that you're used to using. We ran into that here, for example. In Tennessee, there are specific requirements for what must be in the informed consent document related to use of technology. And also our institution had policies related to what must be included. And so if you have a person who you normally see in person and they say, hey, can we do this by Zoom today? I'm not feeling very well, or my car's not starting. If you don't have that informed consent on file for them, you can't do it in a lot of jurisdictions. And so you, again, as a competence issue, need to know that in advance, right? And have accounted for the fact that you will need to have this differently documented for telehealth. Now, you can have a telehealth informed consent and never use it, right? You can have it, they've signed it, they've said, hey, if we have to have a Zoom session, that's awesome. And then you never do one. That's okay. In most jurisdictions, they don't care. They just want to make sure that if you are using technology as part of therapy, that that is very well documented. And again, like, what are the guardrails around that? What are the rules? So you usually have to document informed consent as well when there's technology, because you may not have them in person to sign something, for example. You may need to confirm identity in a way that you weren't used to before. What a lot of jurisdictions require is that if you have a client who you've only ever seen via telehealth, they have to hold some kind of state ID up to the camera so you can verify that they are who they say they are. And so we just need to know about these different nuances and rules before we move forward and make sure that we are really practicing in a good ethical spirit, right? Specific elements that you include in informed consent about the use of technology is going to be, what are the parameters of technology use? And you usually don't have a blanket thing, right? You usually don't say all of these are allowed, great. You may have a client say, I'm fine with you emailing me, but I don't want you texting me. Right? Maybe they feel more uncomfortable with that. Or they may say, you can email me, but only certain pieces of information. And so most jurisdictions don't allow you to have just this blanket, all technology is fine, and you agree to all of it. That clients, you may have seen this in your own healthcare. You go to your physician's office and they have this whole checklist and you have to initial by all the things you're okay with. We see a similar form of documentation with mental health care delivery. You have to talk about security and privacy risks and really explain those, and not just say, oh, I take precautions, you'll be fine. But really help people understand, their role in mitigating risks to security and privacy, and then what you're doing to mitigate those risks as well. You have to talk about backup plans in case the technology fails, and then emergency procedures. This is one where it feels kind of weird and artificial, and some of you may already do this and it doesn't feel weird and artificial, but if you're seeing someone, for example, via virtual platform, you need to know where they are. So at the beginning of every session, you verify what is the location that you are doing the session from. I need the address. I need a backup phone number in case we get disconnected. Because if that person starts telling you something that you need to report, maybe they're very suicidal, maybe they're reporting harm to a child, and you don't know where they're physically located, you're responsible for knowing where they're physically located if you're conducting these sessions virtually. And so, you can't just assume that they're in the same location every time you see them. And, as a matter of training, we just tell, for example, anyone in our clinic, verify it every time. I don't care if they're in the same room they've been in every time you've ever seen them. Verify the address before you begin. Get a backup phone number just to be sure, because we don't always know. And sometimes you can't tell because, again, people can blur their background. They may be on their phone. So don't assume, and always just have it very clearly documented what the emergency procedures look like, and make sure each time you do the session, again, it's part of that kind of continuing informed consent. This is where you're located. This is what will happen if we get disconnected, etc. Okay, so when we think about the ethical principle of justice, kind of transitioning over quickly, telehealth and technology may mitigate a lot of barriers that we see, where it may mitigate accessibility concerns for our clients. If transportation is an issue, if childcare is an issue, if getting time off work is an issue, but they can do a session over their lunch hour. I don't know if that's ideal, but if they have a private office, for example, I think that can definitely increase access to folks and increase that sense of we want to provide services to as many people and not have artificial barriers that prevent, and disproportionately in some cases prevent, people from accessing care. It also, again, can promote that access to specialty providers, specialty training, specialty consultation that wasn't otherwise available to people. And I think a lot of folks have definitely taken advantage of that in recent years, as that's just become more common. I know in my own clinical practice and in our clinic, we found that our clients with social anxiety, they loved it, right? We're like, I don't know, this isn't great, probably, if exposure is the recommended treatment, but it really helped them get to their appointments a lot more easily, because if they had significant social anxiety and struggled with just coming to the clinic, they were much more comfortable doing this via Zoom. And so the question of no benefit because they didn't show up versus some benefit because they still did have contact with their therapist, that did help alleviate a lot of people's hesitance to come in and seek therapy. And then also the safety concerns, right? Just in terms of how is this a justice issue? If you see patients who are immunocompromised, for example, and they may not really want to go to a busy clinic where they're going to be in contact with a lot of people, or if you have people with maybe not immunocompromised, but chronic medical conditions, and they're concerned about, what happens if I get sick, what happens, any range of things, you can help continue to alleviate safety concerns for vulnerable populations through use of these technologies as well. But even though in theory, this is far more accessible than it would have ever been before, there are still issues. The availability of not just broadband, but secure broadband, because there are still a fair number of people who don't have routine access to secure broadband. They may be using free Wi-Fi in public settings, and that is not necessarily, we don't want them using that for very sensitive and very personal topics. We don't want them getting hacked as the result of using free public Wi-Fi to conduct a therapy session, to send a message to their therapist, etc. And then also the accessibility of technology and the equipment that may be needed, because as we saw at the beginning of the pandemic, there were lots of folks who didn't have a sufficient number of machines to simply do the things they needed to do. Now my partner owns a technology company and we have more computers than people in my home. So, there are some of us who are more uniquely positioned for that sort of thing, but even so, like, just having that many people at once using secure broadband can be burdensome. And so, even though it does increase accessibility, there are some folks that still don't have the access that we might expect or think they do. So who is lacking in access to some of the technological platforms that we need, and secure broadband internet to the extent that we can do video conferencing and other forms of technology use? Older adults. Now, again, this is kind of a stereotype, right? This doesn't affect all older adults equally. However, we do have to contend with the fact that there are many people who did not grow up with computers in their homes, and that they are not as aware and used to using computers every single day, because that just wasn't part of their norm. And so we have to, mitigate that so that we aren't denying services to people simply because this is not a technology they're used to. You know, as more people have smartphones, we see more familiarity with certain types of technological access, but it's not always universal that everybody who has a smartphone knows all the different ways to use the smartphone, right? And so we still have to take that into consideration and make sure that, especially when we're talking about not just accessibility, but also security and privacy, that they know how to change their privacy settings if they need to. Do they have a way of encrypting information, or do they have a way of retrieving encrypted information? Another group that is lacking in access is usually newly independent young adults. And so if you think about college age students, not necessarily people in college, but just that age group, they often are very familiar with technology and know how to use it, but may not have the money to purchase the machines that they need, or to pay for the level of broadband that they need in order to conduct certain forms of virtual technology use in healthcare, education, et cetera. And so, they may be using a smartphone when you're thinking, well, you need a computer for this, right? And so we have to take that into account as well, especially think about, the whatever age range or the nature of the population that you typically work with clinically. Rural residents. Now, this has vastly improved for a lot of rural communities where broadband is much more accessible than it used to be. However, there's still a vast majority of rural residents whose access to the internet and access to technology use that we might see in healthcare settings is their smartphone. And so thinking about how that may limit their ability to access some of the tools we may use, right? Like if you're sending a link to an assessment instrument, does that look the same way on their phone that it would if they were using a tablet or a computer? And just thinking about if this is a person living in a rural community, how might their use of technology differ from someone in a more urban setting? How might their access to it be different, et cetera? We also see racially marginalized ethnic minority groups still lacking in access to healthcare and also some of the technologies associated with healthcare. Again, this is sometimes being offset by other efforts, but I know that, for example, clients in some of these groups represented here that we see in our region, they're using their children's tablet that they get for school because they don't have the equipment at home otherwise. And those tablets may not be set to allow them to access certain websites or do certain things. And so they may be able to access their email, but they can't access these other materials that you've sent to them because the school has put limitations on what those machines can access. And so we have to think around those kinds of problems. And then finally, those with more limited financial resources, they may be using more outdated technology. If you're using a platform that requires certain settings or capabilities that their machine may not be updated enough to have, what are the implications for that? Sometimes it's like they say, well, it's fine, I can still use it, but they may not get the security features that you're thinking they have. And so again, we see kind of this intersectionality of different ethical concerns. But when we think about accessibility and justice and wanting to make sure that we're reaching people, we have to understand that some of these technologies that we use may not be equally accessible or may not be equally safe, depending on access to technology. Okay. So I mentioned in the beginning that client engagement can be really different when you're using virtual technologies. So one of the things that we think about in terms of ethical concerns is this idea of multiple relationships. And you may be thinking, well, that refers to like me knowing my client outside the session, or me knowing someone that my client knows, or them knowing somebody that I know, that sort of thing. And that's not really where the ethical concern lies. It's not so much that this will facilitate you having some kind of excessive relationship outside of therapy, but the idea that it has some boundary creep. And so, what do I mean by boundary creep? You may have already experienced this to some extent if you use these technologies. It has a more casual feel, and you may be seeing into their home and they may see into yours. As an example, I usually, when I do these webinars, I do them from home. I don't typically do them from my office. And when I do them from home, I think everyone in the world at this point who's attended one of my webinars, except you guys, sorry, have met my cat. Because she loves webinars. She loves getting up in front of the screen. She has discovered that her little toe pads can work on my touch screen on my laptop, and she has muted people and, moved things around. It's very annoying. But then that means that everyone knows I have a cat, right? I don't care if people know I have a cat, so that doesn't really matter that much. But, you know, that gives people a glimpse into something that if I were their treatment provider, I might not want them to know or see. I might not want them seeing into my home because that gives them more information about me than they would get if we were sitting in a therapy office. And that makes it like the cat example, it may make it more about the cat than about what the client is saying. And so there might be issues with that. There might be issues with you seeing into their living space, and maybe you have a client who doesn't want to talk about certain aspects of their life or doesn't want that to interfere. And we could go on about what that means for therapy, but if you're seeing a client about a very limited problem or issue and then something else is going on in the background and you're like, what is that? Right? That may again decrease that privacy for them, but also it has that sort of level of boundary creep that we might not be comfortable with. And so it calls for us to understand client boundaries in a new way. I mentioned earlier, the phenomenon we noticed with teenagers like laying in bed on their phone talking to their therapist. We had a lot of conversations about, is that going to work as well? Like, are they too relaxed? Does that make it too informal so that they might not actually listen or take it seriously? These were legitimate concerns that we had about if the boundaries are so relaxed, if there are things in their home that are distracting them, if there are things in your home that are distracting you, how does that impact your boundaries with your client and your ability to attend to them in a therapeutic way? Also related to engaging, that's the more kind of, we look at the ethical code, we got to be concerned about multiple relationships, boundaries, etc. Um, but also there's another aspect to engaging that's really important that I think sometimes gets glossed over. And so I hopefully not belabor it for too long. But that sense of connection, and when we provide healthcare services to our clients, when we're talking to them about very personal things, you know, our whole profession is sort of premised on this idea of the relationship and the connection and the rapport. And we know that that's different when we're using technology. Um, we know that things feel more flat in many cases when we use technology. Some of the best practice recommendations for how to engage with clients via video conferencing is you have to use the 25% more rule. You have to kind of put on a show in a way, because we come across as a lot more flat when we use technology. And so you have to kind of over embellish and exaggerate features and speaking and whatever by about 25% to approximate what you feel in person when that individual is talking. So we can control that as providers, but we also have to remember that affects our clients too. And so clients can come across as really flat or really difficult to read when we're using video conferencing or other virtual sort of visual software. We also can't read tone very well when we're looking at emails and text messages. They may not read tone very well either when they're looking at those, but you can all think of examples of a time when you've gotten an email and you thought, well, that was rude. And it wasn't intended that way, but either because of your mood when you were reading it or just the way that that person communicated. Um, again, I have teenagers, they're always like, "Mom, why do you use punctuation in your text? Are you mad at me?" Because using a period is really harsh to them. I'm told that this is universal among their friends, but whatever. I'm like, I will use correct grammar and punctuation. Sorry, I'm old. But, you know, even those differences, the use of abbreviations in text messages, things like that, um, you know, those don't communicate in the same way that we communicate when we're physically in person with an individual. And so we have to think about, how is that rapport different? How is that connection different? You may find it far easier to have that sustained sense of connection with a client that you've already done a lot of work with in person. So like if you see this person all the time in person, and then they're sick that day, so they say, can we just do this over the phone? Can we do it via Zoom, whatever? You may not notice as much that it has an effect on their engagement because you've already established a relationship. But if you have not had that in-person experience, it can be very, very different with that individual. And we think about this a lot when we think about how much we use body positioning, tone of voice, facial expression, silence, and whether or not that is an uncomfortable silence or a contemplative silence, or is it a silence because their machine froze up and you haven't noticed it yet, right? So when we think about all the different ways that technology can affect that engagement and that connection, we have to think about, what do we do on our end to make that better, make that different? Communicating via text or email and maybe putting some additional emotional context in there. How do we underscore the tone of what we're saying? Asking questions when we're engaging virtually, because we may not, and they may have their camera off. We may not even be able to see them, right? And how do we check in, and how do we know, like, how is this sitting with you? What are you feeling right now? And how do we do that in a way that benefits the client and isn't something that harms therapy? The other issue to consider is that oftentimes, um, we think, oh, well, we're still reaching out, we're still seeing this person via remote technology, this is great. They can still feel really isolated and lonely, even though they've just spent an hour talking to you. And so we can't just think that the fact that we still saw them offsets that disconnect that they may feel from other people. Okay, then we transition to assessment. There are a lot of concerns related to assessment via telehealth. Like I said, some of the assessment companies that produce these instruments, they want to work really hard to make this accessible and easy, and hey, it's still ethical because they want to sell you an instrument. So I do think they are working hard. I would love to think it's for purely magnanimous reasons, but they want to make money. So I do think there's been a lot of effort made toward, let's transition some of these tools so where we can use them using technology, and let's make this easier. But we still have a lot of things that we're obligated to ask and we're obligated to investigate. So there is no one single answer, because if we think about all the different range of assessment tools, the range of populations that may be using these tools, it varies pretty substantially. So the first question is, are the instruments able to be given virtually? Now, this is a two-part sort of ethical concern. One is just the logistics, like logistically, can we do this? Can you do block design on video, right? If you're giving an IQ test, can you do block design? So some of these things we think about in that very like straightforward technological sense. But there's also the question of, can it be given virtually and still be effective, right? There are lots of things that we can do on camera, but they weren't normed on camera. They weren't standardized on camera. And so how does that change the nature of the information that we get? We think about this. If you think about research for a minute, not healthcare, but if you think about research, if you're sending out a survey and it's an online survey, a concern might be, is it legible? Does it look nice? Does it store the data appropriately? Like, we're not talking content, just some of these straightforward things. But then another one is, how do you know that the person filling out the survey is the person who says they're filling out the survey? We might have a similar concern about assessment instruments. If we send out a form for a client to complete, are they completing it, or are they calling their parent in the room and saying, what do you think I should say here? Or are they asking their partner, like, how would you answer this if it were about me? What does that do to the results? For some instruments, that helps, right? But for others, that might invalidate it. And you also have to remember, if they're sitting by themselves in a room in your practice completing that instrument, they may not be able to ask anybody else what they should put. And so you're going to get different information. So it's not just about like the logistics of, can I actually do it? It's also, is it still any good? Right? Another concern, issues of copyright and test security. Will that company allow you to give it virtually? I mean, a lot of us can build platforms that will do this, right? There's some pretty easy to use survey platforms out there, SurveyMonkey, Qualtrics, RedCap, things like that, that if you have access to that, you could conceivably take an instrument and put it in there and send people a link and they could fill it out. That might be illegal, right? It might be a violation of copyright. That test producer may be really upset knowing that you're distributing that in that way. It's that issue of, just because you can doesn't mean you should. And so we have to think about that and what that means for transmission of results, knowing the platforms that are being used and whether or not those results are transmitted securely, thinking about safe storage of those. If you download a report from, Q Global or Q Interactive, like, where are you downloading it? Is that a safe location? Quality of observations. This could be impacted by any number of things. It could be impacted by that engagement factor I was just talking about, where if you're assessing somebody's mental status and you decide their affect looks pretty flat, is it really flat, or is it flat because the 25% rule is kind of sucking the life out of them, right? And so, you know, how good are your observations that you're making? There's also that issue of, does the technology interfere? If you are giving a cognitive test and there are gaps, delays, freezes in the technology, and it's, you know, a timed test, for example, how is that going to impact your conclusions? If you are screening and the person if you're screening for dementia, for example, and the person's video feed keeps cutting out or their audio feed keeps cutting out, you may estimate their abilities far differently than if they were sitting in front of you. And it could be for better or for worse, right? Like if it seems like, oh, they're not answering coherently, this is taking them a long time, you might rate them as performing more poorly than they actually are. Or what many of us might do is also think, oh, it's the technology, I'm sure they're fine. And you may actually overestimate their ability because in your head, you're thinking, oh, it's the technology that caused this to be less coherent, you know, slower, more disjointed, when if you were in person with them, they may have still performed that way. So we have to think about the quality of those observations and then how they affect the quality and basis of the conclusions that we draw based on that information. Another issue related to testing and virtual technology is where the individual is when they are doing the evaluation. And so if they're in their home, can you establish an optimal testing environment if you need quiet space, uninterrupted space, if it's timed and, you know, they're getting all these distractions coming in, you know, that's not going to be an optimal testing environment. And so, you know, the conclusions you might draw from their responses when they're in person and you see all that versus when they're in this distracting environment are very different. Um, for a lot of instruments, a concern too is they don't have established validity yet for virtual administration. I think that's improving. However, this is going to be variable depending on which test you're using, how long it's been out, whether it's really highly specialized. And so there's not a lot of people to norm it on. And so what do we know about the reliability and validity of that test being administered in a virtual space? And I've already kind of mentioned these latter two throughout, but just connectivity issues and how to mitigate that, and whether or not you then invalidate a test administration because it's timed and this thing happened that interrupted them, or whether it would be technology or something in the environment, and just that nature of virtual interaction and how that can affect our ability to connect what the client is doing or saying with how they present themselves. You know, technology also impacts our business practices. I think, you know, one thing that we automatically think of in most places, you know, this is not an issue anymore, but electronic health records and how we keep our records and whatnot. But with regard to kind of issues outside of EHR, when we think about record keeping, some jurisdictions still require what's called a wet signature. They won't take digital or electronic signatures. And so if you still have to have a real signed copy of something, how do you get that back and forth, and how do you transmit it in a secure manner? When you are keeping records about assessment or therapy or consultation or supervision or any other service that you're providing using virtual technologies, you still have to document the modality that you're using and any disruptions in service. And so it feels odd, but a lot of times you're going to start out, the client was seen using the HIPAA Zoom platform. They logged in, there were connectivity issues, they logged back out and logged in again. We resumed without difficulty. You know, you still have to put those sorts of things in your notes. And then making sure that, I mean, we always like to make sure we have people's emergency contact information on file, but when they're sitting in front of you in your office, that feels less necessary than if you're seeing them via technology, or you get a text message from them that says something and you're like, I have no idea where they are. Right? So always making sure at the beginning that you always have that information is really important. With regard to other business practice related things, we have fees using online payment systems and security associated with those. Oftentimes you have business affiliation agreements with these online payment systems. And so you want to make sure that you have a lot of things spelled out about client information security, about, your information security, et cetera. And then finally, I mentioned in the beginning, concerns about reimbursement and wanting to make sure that what gets reimbursed via telehealth and what does not. And where you may see a lot of differences is with regard to what we just spoke about with assessment, is that especially if the testing company that you're using says, we don't really know, we don't have virtual administration of this, and you somehow give it virtually, you may be denied payment. So you just want to be really careful about sort of, again, knowing all of those rules and restrictions. In terms of training and supervision and use of technology, there are a lot of advantages in using technology and training and supervision. This has really streamlined a lot of training. I mean, you're in a webinar right now, and most of you are nowhere near where I am physically, right? I'm in the mountains of Northeast Tennessee. And so it makes learning from different people far more accessible. It makes supervision and consultation potentially far more accessible. You can also, I mean, I don't know about you, but like when I attend a lot of webinars like this is when I save up all my laundry for the week and fold it, right? So I'll be folding like 10 loads of laundry while I'm listening to a webinar. I'm not sure that's the most effective way of learning, but two birds, one stone, it's fine. But it does make it more accessible. It makes it more convenient when you can watch it on your own time or record it and watch it back later if there are parts you want to revisit later on. But we also have to think about important ethical considerations. If we're thinking about supervision in particular, how that affects the needs of the supervisee, whether or not they feel comfortable doing this over technology. Some folks, this may be great. I did supervision, for example, with one of our senior grad students right before she left for internship, and she was working in a really remote primary care clinic up in the mountains. And it was great where she could text me things just on the fly with the client in the room. Is this something I need to report? It was a really easy, accessible way of reaching the supervisor. Other people are less comfortable with that, either as supervisees or supervisors. So you have to check in. There may be licensure and jurisdictional concerns. There may be rules about how much supervision can occur via telehealth. There may be rules about where that person is located and whether or not they have to be in the same state. Another issue is assessing competencies of learners and supervisees via virtual technology. How do I know if I'm folding all my laundry while I'm listening to something that I'm really getting it? And do the people who are assessing me know that I was doing other things, right? I use the folding laundry example because that's pretty mindless and I can still pay attention. But again, you could have people who are, in meetings watching something with their headphones in. And so they're trying to do too many things at once and they're not going to get the competency that they normally would get. And again, as with any other thing, access to technology, I think, that can make it much more accessible, but for people who may not be able to routinely get to the technology, that may be challenging. And then use of best practices in online training. And are you doing the things you need to do to be effective as an instructor if you're providing education? And then in terms of interprofessional practice, because in many healthcare settings, we're working with providers who are of different disciplines and specialties and backgrounds. And this can definitely increase opportunities for specialty consultation or collaboration with other people if we're using technology to facilitate communication and relationships. It can allow for flexible meetings or conversations across providers in different locations, which is really nice. A colleague of mine routinely had to, this will not have any context for those of you not in Tennessee, but she routinely had to drive to Nashville for quarterly meetings with her team. Sometimes they were quarterly, they were like every other month, but Nashville's about 5 hours from here, 4.5, 5, depending on traffic. And there were always going to be people who couldn't make it because I have to be back in time for this, or car trouble, or I have this other thing. And suddenly, when everything went virtual, she was like, oh my God, nobody misses any meetings anymore. Right. And I get so many hours of my life back because she was often driving there and back either in the same day or within a 2-day span. And so this idea that a 3-hour meeting could occur virtually and it increased attendance and more people could be brought in. You could bring in a specialty person for a few minutes to talk with them and then they could go. Whereas if you expected them to drive to Nashville to get there, that was not going to happen. So those things can be great. But where you run risks are things like forming interprofessional relationships. You may not have as much opportunity to kind of mingle and talk with people like you do in person. And I mean, if we think about conferences or other training opportunities we've been to where it's in person, or you're going to grand rounds, for example, you chat with people, right? You get to know people more. If you're in a meeting that's on Zoom, everybody's muted unless it's their turn to talk. And then they just kind of jump in and say their piece and then they mute themselves again. So it can actually limit that relational piece that can be vital for consultation and networking and collaboration. You may get a lot of differences in opinion about whether virtual technologies are useful or effective. And so you may want to do this in collaboration with other people and they're like, nah, we don't do that. Or we found that it doesn't work. End of story, shut it down. And so then, you're left with this more limited opportunity for collaboration because somebody may or may not be comfortable with the technology, or their institution or agency may not allow the technology or may use different ones. And so those sorts of things are still considerations when we're looking at interprofessional practice and how to best promote collaboration and effective service delivery for our clients when we are thinking through using virtual technologies. All right, so kind of wrapping up from today, virtual service delivery has a range of advantages, but also a range of ethical challenges that we have to address. Best practices are always evolving. And so it's up to us to stay on top of that. Consult the literature, consult your agency or organization. I've spent a lot of time talking to lawyers, for example, as we do more of this and figuring out like what is legally permissible, what is something that we don't even know yet, what the disadvantages are. But it's ever evolving. And so, it's something that you will constantly need to be updating and reaching out to people. And then working with clients to help them get up to speed on these different technologies. There are some unique challenges that are disproportionately represented across different client populations or groups, different types of therapy that you may do, and different agencies and what their comfort level is or what they will or won't allow using telehealth. But always planning ahead and thinking through these difficulties and really having a clear set of guidelines for yourself as to how you're going to address these issues and how you're going to communicate these issues to your clients and other providers in your agency can help mitigate a lot of these concerns. Most of these are not, none of them really are insurmountable. It's just some of them are things we have not encountered yet. And so figuring out in advance, what are the limitations of the things that I'm using and how can I offset that? How can I talk to people about that so that everybody is on board and aware of those limitations? That can really help you out. All right. So that is all I had for you in terms of slides. I'm going to visit the Q&A here. Okay, so the first one here, how do you see AI impacting the field of psychology and social work? I think it's going to be really challenging. I know, for example, that there have already been some controversies in this, and like platforms like BetterHealth and these other apps that they're promoting for therapy and mental health A lot of the screening that's done on these apps is done by bots, and I'm not sure patients know that. So as they're kind of asking questions about what sorts of things are you being seen for, or what do you need help with, they think they're communicating with a person, and they're not. And that's not universally true of all of them at every stage, because there are real therapists who work for some of these. But in terms of AI's use, there are a number of platforms out there that say that they provide psychological help or advice that are using AI. And, you know, I think the challenge in that is just transparency and communication so that patients know they're not talking to a human. And then also the obligation on us as a profession or field to put limits on that if it's harmful. There may be some great uses out there for AI that can help us do the work that we do. We've already seen that in a number of contexts just in academia. But I think we have to know the limits, and people have to know it's kind of like buyer beware. You have to know what you're doing, and you have to know what you're interacting with. And I think that's where it kind of falls short. Oh, the question about judges. I heard that virtual conversations via Zoom, et cetera, have been shown to be as sound as in person. If studies show it, why do judges not believe it? I don't know. I don't know. And their lawyers don't either. And so that's a challenge. And I think it's on us to kind of know the people that we're talking to and communicating our results to, what do they think of this technology, and what do we need to do to mitigate their concerns or communicate in a way that still assures them that what we're saying is valid, right? Let's see. Here's one. Do you believe what you described as relates to how laid back or comfortable a client can be during appointments plays a role in how serious our profession is taken or not taken, and the impact of what our serious work has on reimbursements? Probably. There's so much variability in how people view what we do as mental health providers. When I teach, I ask students to recount movies and shows they've seen that depict therapists and describe what those therapists are like. And if you were to just go based on what media sees us as, we're all doing terrible things, right? We're all either on drugs or having sex with our patients or incompetent. This is not good, right? And so I think, there are varying impressions of the mental health field out there. And I think if sometimes people are pretty relaxed, it may mean they don't take it as seriously. They don't see us as professionals. I think in the context of telehealth, where they may be more relaxed, is like they're in their house, right? It feels very different if I'm editing a report laying on my bed than editing a report sitting up at my desk in my office, right? It just has a different feel. So I think there are multiple things impacting that laid back feeling, but I also think that affects parity and reimbursement rates as well. Because if our work is not being seen as, there's healthcare with a capital H and then healthcare with a little h. And I think a lot of people think psychology and social work and counseling are healthcare with a little h, and that's a problem. So, oh yeah, wondering how the end of the broadband subsidy will impact access to virtual care. I cannot imagine it would be good. If people are not routinely provided resources that they need, and this stuff constantly has to be updated, right? That's the part that I feel like gets lost, is it's not just the broadband, but the technology. I had a laptop go bad in March of 2020, and the keyboard went bad and it was under warranty, and I tried to get it replaced, and they're like, or tried to get it fixed, and the company was like, nope, everything's shut down. And so they said, we'll give you a new laptop. So new laptop in March of 2020. That laptop is now on its dying legs, and that's only 4 years ago. And so there's a lot with continued subsidies and funding for access, that it's not this one-time shot that everybody kind of was like, okay, we did the right thing, it was the pandemic, now it's over, we don't have to do it anymore. And that is going to disproportionately impact people, especially those with limited resources, limited access, that sort of thing. Here's a question. Also, does the online format and privacy concerns limit access for clients who are not housed or AKA homeless? Yes. Because their access to technology is profoundly limited, and it may be limited to public settings like a library or a shelter where that's not private at all, you know? And so I think there are still large segments of the population that we can't reach if we do more in the way of virtual technology. Now, there are still ways of reaching those populations. And I know there are agencies that are helping out with this. Like I know here locally in my community, there's a multi-provider agency that works with our unhoused, and they have medical services, right, and mental health services, but they also have technology rooms where if a client needs to see a specialty provider, they can still do it via telehealth in a private setting in that space. But then there's all these limitations still, right? Like it has to be available because they're trying to schedule it with a lot of people. The person has to come to the clinic in the first place. So there's still barriers, even though there may be efforts by limited organizations to address that. But yeah, that's definitely a concern. Looking at this next one. What if an adult client is comfortable with their child playing in the room during this session, but you know it will negatively affect the child? Oh, yeah, that's always tough. I mean, this is where you're having a conversation with your client in advance as part of that informed consent process about privacy and security and what is and is not okay, and how the things that you discuss may not be healthy or appropriate for their child, even if they say it's fine, right? Like they may say it's not going to have an impact on them, but it's always that sort of scenario of, you know, what if your client starts talking about domestic violence in the home and the kid is sitting right there, right? So, you know, you need to have some kind of way out of that, but it's a conversation, again, that planning ahead and talking with them about who's going to be in the room with you, and let's talk about some things that if this comes up, we need to find alternative places for that other individual to go, or we need to find another time or space to discuss that. But I think that's something that you can always bring up in a pre-planning way. And if they continue to not abide by it, you can talk to them about this is having a detrimental impact. And we can always sort of set the rules about our own therapy stuff. So, you know, if they say, well, there's no way I can't do therapy without having my kid in the room, it's like, well, then there are limitations now being placed on therapy. We cannot talk about these things, and I can't be as effective of a provider if we can't talk about those things. And just have a conversation about what that looks like in advance. Okay. How is doing trauma work in a virtual world? How does that impact evidence-based practice? I don't know. I haven't seen a lot come out on that yet. It's an interesting question, certainly. Because for some people, it may feel more comfortable to talk about traumatizing things when they're in their own space. It may feel different than if they're sitting in a room with another person. Some people may feel less vulnerable because they feel like they have a little bit more control over the situation. Other people, it may be more distressing. They may feel more disconnected. You may be less able to assess the impact of that conversation on them. So I think it's definitely something that, you know, you also want to consider in the context of what type of therapy you're doing and whether or not it's appropriate. This is where I would just really recommend consultation. You know, talk with other providers and see what they think, and just talk with your client. Again, that pre-planning and setting up sort of ground rules about what are we going to do if this gets too distressing? Like, you know, or how are we going to make sure you're okay after you do this? Because I won't physically be there to assess you. So yeah, and then I've got 2 minutes left. So one more question. Let's see. This is related, I think, to my comment about therapists in movies and TV. I think the problem is that what we see in the movies, again, impacts the seriousness of what we do. We're not the only profession that has unethical individuals, but due to how intimate our professional work can become, it's really sticky. Yep, hard to undo those thoughts with those who are not clinical. Yeah, I mean, sad, but yeah, I joke about this with my colleagues who aren't clinicians. They're just like, "What? You mean you don't sleep with your clients? Ha ha ha." And I'm like, "Oh my God." And I mean, they know that, but I do think it makes our profession look worse when we're depicted in a way that is either grossly unethical or incompetent or just doesn't really estimate well what we do, right? Um, so yeah, that's a larger problem. All right. So that is it for the questions, and it is 11:30 or 10:30 your time. So thank you for having me. Hope you've enjoyed it.
Thank you so much, Dr. Stinson, and thank you everyone for being here. We appreciate it. As we close out this webinar, you will automatically be redirected to a very short survey. We very much appreciate you taking a minute or two to take that. I put the link for the handout and a PDF of the slides. Those can be found on our website. The recording will be available within the next few days, and it will be available for 90 days. So feel free to send that off to people who you think would appreciate it. And we hope to see you at a future training. Thank you, everyone.